I'm going to say hello real quick because I'm going to introduce Elizabeth St. Clair, who's presenting this workshop. Welcome, everybody, to workshop session 3A, supporting a family member with severe emotional dysregulation. My name is John Kirkman. I'm a family support specialist with AFF-CNY. I work for the Kinship Caregiver Support Program, and I work out of the Ithaca office in the Central New York region. Before we begin, I want to point out what we're doing here. And I'm going to be the room monitor today. We understand that these workshops can be triggering. We view this as a good thing. We ask everyone to lean into those feelings of discomfort. Seek to understand, not to be understood. Please hold all questions until the end of the presentation and be sure that cell phones are muted. We need to actively listen to learn. Now, these workshops are not support groups. Please don't mention your child's name or anyone's name. These workshops are being recorded. While we do limit those who can view the recordings to those who registered for the conference, we ask that you not share or state anything that you wouldn't want your child or anyone else to hear in the future. If a room monitor feels you are oversharing, you'll be asked to stop engaging in that conversation very gently. I want to also remind everyone that training certificates are available for this conference. Please be sure to sign the sign-in form being passed around if you would like a certificate. If you haven't signed the sheet, a certificate cannot be issued. And with that, let's get started. Thank you.
Thank you. Yeah. Hi and welcome. I'm Elizabeth St. Clair, and we're here in this workshop to talk about borderline personality disorder, or as it's sometimes known, chronic emotion dysregulation. And also to talk about a program that's been around for 25 years called Family Connections. That's a program for families who have a person who they're trying to support with BPD or CED. So borderline personality disorder makes it really hard for a person. It affects it's a mental health disorder. It affects the way that they think about themselves, the way they think about others. Makes it very difficult for a person to function really in normal life activities, like difficulties holding a job, very, very difficult to have stable relationships, to be in a family, and to, basically just have a life that's worth living. Everything is often in chaos and turmoil when a person has chronic emotion dysregulation. So BPD or CED is a very serious disorder, and it's very, very poorly understood, even among therapists and professionals that you'll encounter. If you know a person with BPD and they've gone to an emergency room, they're just as likely to encounter someone who has no idea what they're dealing with and has no idea how to treat such a person. So it is very poorly understood and quite stigmatized. I'm sure a lot of people's reaction, they hear BPD and they think, run, get out of here. This person is going to be impossible. No one can relate to them. That's the stereotype of what a person with BPD is like. So today we'll talk about the disorder, treatments, and the Family Connections program. So in 1998, I adopted a child from China. She was 10 months old. And from the start, she and I were kind of a poor fit. She was very insecurely attached. She could not relax. She had night terrors until she was about 8 years old. And I did not know what to do with her. I had no idea what to do with her. I could not soothe her or calm her. The responses that I had to her were not effective, and she learned not to trust me and the way that I was providing care for her. So things escalated. a lot. And by the time she was in high school, she was dealing drugs in the stairwells of the high school. She was drinking herself on a weekly basis into unconsciousness. She was using a lot of drugs. She would frequently get picked up on the streets of New York City where we live, unconscious by an ambulance, by the police. She'd get hauled off. She engaged in risky sexual behavior, many suicide attempts, many encounters with all kinds of, police and ambulance and the like. My life was in total chaos and disaster. I ultimately stopped working. I just couldn't handle both what was happening with her and a job. So our family was really in pretty bad shape at that point. She has a sister who was extremely alienated from both her and me at that point. When she finally, after a suicide attempt, was diagnosed with borderline personality disorder, I knew nothing about it. And I went on Amazon and ordered like 100 books, and I stumbled on Family Connections, and it said it's a free class. So I thought, well, what the hell? It can't hurt. So I registered for it. And I really don't think it's an overstatement to say that the program and the skills, the things that I learned in the program saved my life. And they saved her life too, I think, as well, and made us into an intact and more or less functional family at this point. So, and then I trained to become a Family Connections leader and started leading the classes myself. I really wanted to pass on to other families who were in pain and struggling as I was, some of the things that I had learned that helped me so much. So all of us in Family Connections are family members who wanted a better and more effective relationship with our person and wanted to improve our family functioning. We're all volunteers, and so the program is completely delivered by volunteer family members to other family members. The program was developed 25 years ago by clinicians from McLean Hospital at Harvard, who noticed that when a person with this diagnosis of BPD or CED had family support that was effective, emphasis on that word effective, that the person fared much better. Their functioning improved and their ability to regulate their emotions improved when their family was effectively involved with them. So the program was, again, developed by health professionals. I am not a health professional, and the people who lead the Family Connections classes mostly are not health professionals. Sometimes a clinician will come along and want to lead the class, and that's good too. But other than that, we're all volunteers. And we're motivated to lead Family Connections because we know what a profound difference it made in our lives. So we want to give that back. So if some of the things that we'll talk about BPD, if those resonate with you and in your family, welcome to the club. None of us ever wanted to join. BPD is a program of the National Education Alliance for Borderline Personality Disorder, and our goals are to provide education both to families and to others. For example, first responders, people who pick our kids up in ambulances, either as a result of some sort of incident or a suicide attempt or whatever the reason is. Oftentimes those people They know nothing about BPD, and they're full of stigmatizing ideas about who this person is. So we wanted to educate families and others. And we wanted to learn skills for improving our families. And we wanted also to experience support and build that sense of community that we've been talking about all day and how important that is. So those were our goals, and we've been around for 25 years. So truly, we're a collaboration between and among family members, clinicians, and people who have lived experience of BPD. The organization includes all of those people because we know that, again, as has been evident from all the people who've spoken today, you can't do it alone, and a clinician can't fix things without active involvement of the person, the family, and the community. So that's kind of what we're about. The program, the classes itself are offered over 12 weeks. It's 2 hours a week, and the classes start with psychoeducation about the disorder, what are the behaviors like of a person who has this disorder, and what does the family situation look like. And then we also teach skills, interpersonal skills, mindfulness skills, distress tolerance skills for family members to help them cope in these situations. And finally, again, that all important piece of the community and support. We have extensive resources on our website. I think the website address is down there. It's just borderlinepersonalitydisorder.org. And we continue to be supported and guided by clinicians. We have a clinical advisory board that works on the program, makes sure that it's taught in an evidence-based way, and just that the program is being done in accordance with the research and science about how people with borderline personality disorder can be helped. So BPD is a mental health disorder, and it's about managing emotions. People who have BPD are intensely reactive. They're different from the rest of us. Some of us may have a really acute sense of smell, and you can walk into a room and say, I know someone has been cooking lentils in this room because I can smell it. Other people wouldn't smell it. A person with BPD is a hypersensor of all kinds of emotions, and they experience an emotion in a way that is exponentially more intense than neurotypical people do. And they react to that emotion also in a very intense way. And then they may have a lot of trouble getting back to a baseline level of functioning. So instead of when you get upset and then something happens and you react to it and 2 hours later you feel better, a person with BPD, they might get 10 times more upset, and it might take them 3 days before they're back down to where they can think rationally about what's happened. So as a result of that, they have really unstable relationships. They have a really distorted self-image. They might be very impulsive, and it's very difficult for them to function. If your boss, you have BPD and your boss looks at you funny, you might really have a big reaction to that and quit or get angry or do something that would make other people say, what? What happened there? But I want to say that BPD is totally treatable. There are treatments around now, in contrast to, say, 25 years ago, there are treatments around now that can be very, very effective for people with BPD. And again, they do better if their families are on board with that kind of treatment, know the treatment themselves, and participate in an effective way. So BPD is a complicated disorder. There, according to the DSM, I assume you're all familiar with the Diagnostic and Statistical Manual that that mental health professionals use for diagnosing mental disorders. There are 9 criteria for BPD, and in order for the diagnosis to be made, 5 of the criteria need to exist. So fear of abandonment, someone might say, be 15 minutes late for, maybe a mom is 15 minutes late coming home. Someone with BPD, oh my God, she's never coming home. She's abandoning me. She must be so angry. They have a very heightened fear of abandonment and will do all kinds of things to avoid that particular feeling. The second diagnostic criteria is intense and unstable relationships. This is kind of a pattern, and they alternate between extremes of, and I know this was true with my kid, you're the best mom in the world in hour 1, and in hour 3, I can't believe they ever let you be a mother. You're so horrible. And that is very characteristic of BPD, is those extremes of very dichotomous black and white thinking. The third criteria is a really unstable sense of themselves. They don't really know who they are, a lot of identity issues, and just not a good sense of what are the outlines of their being, their personality. The fourth one is impulsivity. Really, and in at least 2 areas. And most of these are potentially self-damaging, like spending, risky sex, binge eating, drugs. The next diagnostic criteria is self-harm, including suicidality. Many people with BPD engage in a lot of self-harming behavior, cutting, burning, kind of getting into accidents. Cutting and burning are 2 very, very big ones, but also other kinds of self-mutilation, and of course, suicidal behavior. Next one is frequent mood swings, which they call affective instability. So again, in hour 1, they very loving, very generous, funny, happy. Hour 2, unbelievable rage and just completely feels out of control. The 7th one is chronic feelings of emptiness. It's like they just can't figure out how to satisfy themselves, how to fill themselves up. They just feel kind of empty all the time. And explosive outbursts, intense anger, really difficulty controlling their anger. If you've ever lived with someone who breaks things, punches holes in walls, threatens people, that is one of the diagnostic criteria. And finally, the last one is dissociation. And this can be, either transient, sometimes it's stress related, and sometimes it can be very, very severe. So these are the 9 diagnostic criteria. And again, the presence of any 5 gets the diagnosis of BPD. So you can see there are a lot of different possibilities for the presentation of BPD. I think somebody figured out 256 possible presentations. So someone might not dissociate, and they might not express inappropriate and very intense anger and rage, but they might have the other diagnostic criteria. So it's a very complicated disorder to diagnose. And let's see. So it's thought that there are 5 different areas in which this dysregulation occurs. So remember that BPD is a dysregulation disorder. What that means is that the person cannot regulate themselves. They cannot regulate their emotions. And so the 5 areas where this might occur is, first of all, cognitive dysregulation, the one on the left. They might be very paranoid. They might have incredibly distorted thoughts or irrational beliefs or fears about things. And they often lack the ability to think in a complex way. Behavioral dysregulation, again, here's the self-harm, impulsivity, escape behaviors, and disruption in self-care. Like a lot of people with BPD have a lot of trouble taking care of their bodies. They don't shower. They may not be able to wash dishes or take care of themselves in that kind of way. It's a behavioral dysregulation. There's self-dysregulation. They have often very, very low self-esteem, self-loathing. They don't feel motivated to do anything. They can't envision ever being able to build a life worth living. I remember my daughter, who had a lot of self-dysregulation, saying, "Why should I go to therapy? I can't imagine a future for myself other than being a homeless drug addict. So what's the point of all of this? So why are you hawking me about getting into therapy?" And interpersonal, of course, chaotic relationships, which then can result in isolation. They feel a lot of rejection sensitivity and intense loneliness, exponentially greater than, those kinds of feelings that most of us have. And then emotion dysregulation, they feel fear, shame, guilt, anger, and anxiety, you name it. BPD is not at all uncommon. Again, there are way over 200 different presentations of the disorder, which results in a tremendous number of misdiagnosed cases. And it affects, as you see there, between 1.6 and 3.9% of the population. So that's a lot of people. That's somewhere between like 5.5 million and 9.5 million people in the United States. So it's a big population. And if you think of each person with BPD has a constellation of family members around them. And those family members are suffering as well. They often have no idea what to do. They don't know what's going on. And they're struggling and in crisis. It affects men and women equally, although men are much more likely to end up in prison than women. Women are likely to end up, really seriously medicated, and men are often misdiagnosed and end up, becoming involved in the criminal justice system. And we know that being adopted or being in foster care is a risk factor for BPD. There are psychodynamic characteristics that overlap. You know, all of the issues that adopted people and people who are or have been in foster care have the same issues with trauma, separation, abandonment, identity disorders, rejection, shame, guilt. They have a lot of trouble with intimacy, and they really do not have the ability to find mastery and control in their lives. So that's kind of the classic description of someone with BPD. This is, we know BPD is way behind other psychiatric disorders in funding. There's been, over the years, just very a fraction of the funding for BPD as there is for bipolar disorder or schizophrenia. Now, this isn't the official line, but I think that's because there are drugs for schizophrenia and bipolar disorder, and there aren't for BPD. So you can draw your own conclusion from that. BPD symptoms typically, most often actually, emerge in adolescence and early childhood. The condition seems to be the worst in that 18 to 25-year-old age group. We see lots and lots of families who they feel like they lost their child somewhere between 13 and 18, that their child seemed to be perfectly normal, whatever that means. And then all of a sudden, lots and lots of problems start to happen. That's not uncommon. A lot of adults who get the diagnosis realize, they say, oh, now I know, I've been feeling that way since I was a very young child. So this is a very controversial topic because the mental health profession believed, and still to a very large extent believes, that nobody should get the diagnosis before age 18. That, oh, if you give a 13-year-old that diagnosis, they're stigmatized, the school will know, everyone will know, they'll never get out of it. A person with BPD, oh my God, get away from them. That's what you're putting on them, is a label like that. And that is not what we believe. We believe that early diagnosis can really help the person get the right treatment and help the family environment improve. So we advocate for much earlier recognition and diagnosis and treatment than age 18. BPD very rarely presents alone. So you see here, 90% of people who have a BPD diagnosis also suffer from anxiety, major depressive disorder, and all the way down. It just never presents alone. Often people with BPD have 6 or 7 or 8 different diagnoses. And some of them are amenable to medication treatment, like maybe anxiety and depressive disorder. And so they're maybe treating some of the comorbidities, but not the BPD itself. And in fact, you know, most people with BPD also will have some kind of mood disorder. That's just goes kind of hand in hand. So, you know, treating all of this can be like peeling an onion. And I have developed a little bit of empathy for a clinician who is trying to make an appropriate diagnosis. How do you pull apart all of the different symptoms and issues and figure out when a BPD diagnosis is appropriate. It's kind of like really like peeling a whole bag of onions. So BPD can be lethal. It's really serious, and it can be, quite lethal. At least 80% of individuals with BPD have self-harmed. They've cut themselves, burned themselves, they bang their heads against a wall or otherwise injure themselves. And if that behavior is not connected with suicidality, then what we know is that it reduces people's emotional pain. My daughter has said this to me many times. When I've said to her, why do you take a cigarette and burn your arms? And she says, that intense physical feeling helps me with the emotional pain I'm feeling. So, however, we do know that self-injury increases the risk of suicide. So if a person is engaging in self-injury, even if they're not suicidal at that particular time, it does increase the risk of suicidal behavior. At least 65 to 70% of people with BPD make at least one suicide attempt. And around 10% of people with BPD actually die by suicide. They make a completed attempt. And among all suicides in the United States, somewhere between 9 and 30% of people who have completed a suicide attempt, who've died by suicide, were BPD sufferers. So, where does BPD come from? How does a person get BPD? And there's been a body of research. It's still ongoing, and the answers are not complete. What we do know is that individuals with certain innate temperaments and temperamental vulnerabilities, together with environmental factors, can trigger a pattern of chronic emotion dysregulation. So, if you think about different people that some of them are enormously sensitive. If there's an emotion somewhere, they will feel it in a big way. And they might be very reactive to it. And then if once they're emotionally aroused or activated, it takes them a really long time to get back to baseline. Those are the innate characteristics that, when combined with a lot of invalidation from many places in the environment, can lead a person to develop BPD. So we know some people are more sensitive to emotional experiences than others, and they return to baseline more slowly. And the environmental factors might include abuse or trauma, which lots of our people have experienced. Or it might just mean in a family that the child is a poor fit for that family. I mean, for example, sort of stereotypical example, a very sensitive boy in a family who's very, very sensitive and reactive and has a lot of trouble once being aroused, going back to a normal emotional functioning. Maybe he likes to dance and he thinks he might be gay. And he lives in a family someplace that does not approve of any of that. They think he should be starring in Friday Night Lights, and that, that's the kind of boy they want. That kid can feel very, very invalidated, both by the poor fit in the family, but also by the culture that child lives in. And that can also be true with racial trauma, sexual identity trauma, and all kinds of ways that I bet every person in this room could talk about how their environment has invalidated them. And for some people, it's generational, particularly when we're talking about racial trauma. There's an awful lot of just invalidation hitting that kid from the environment. And if they are very sensitive, then that is a huge, huge risk factor. So BPD is very stigmatized. And people with BPD are stereotyped in ways that aren't accurate or fair. And the stigma comes from a real lack of awareness and education about what BPD is, and a belief that once you've got it, you've always got it, and it's not treatable, which is not true. So people, when they see someone with BPD and they're maybe very, very dysregulated, people think, well, what the heck is going on? It does not make any sense, because they don't understand the reaction that's happening, and they make judgments about the person that they shouldn't be doing that, how they're acting is crazy. What they feel is it's not right according to the facts. All of that can really stigmatize and further invalidate a person with BPD. A person can start out with those innate characteristics that I talk about. And if they grow up in a family that's very validating and they're not experiencing any chronic invalidation from other sources, then maybe they don't develop BPD. But a person who does experience a lot of that invalidation coming at them, then their emotions become more and more heightened. They don't recover in between an episode of being very dysregulated, and the next thing comes along, and before you know it, they're even more dysregulated and just spinning out of control. So that's what BPD is like. And even the term borderline personality disorder is horribly stigmatizing. I mean, what does that mean? Borderline personality disorder. And it's an old Freudian term. So in Freud's day, they thought, well, there's neurosis, which is, what all of us have. And there's psychosis. And then there's this whole gray area. And we don't know what to do with it, and it's not treatable. So they called it borderline. But today we know that BPD it's a disorder of the emotion regulation system, and that it is very treatable. So there are several treatment settings for BPD. There's outpatient, there are partial hospitalization programs where a person will go, say, for several hours a day and get intensive treatment, but they live at home. My daughter did that for a year. There are residential programs where they go and live in a setting. And usually those kinds of settings are really good for people who have a lot of comorbidities. So they can treat the BPD and the other comorbidities at the same time. And then there are psychiatric hospitals, both intensive and intensive inpatient. These are not for treatment. Nobody who has gone to an emergency room because they've either tried to commit suicide or had some horrible incident, they don't end up getting treated in the ER. The ER is for safety, not treatment. And boy, did it take me a long time to understand that, because when my kid was in a really bad way, that was the first thing I wanted to do, is haul her off to an ER. And I found after a few experiences of that it made it a whole lot worse. So BPD does require very specific kinds of psychotherapy. There's no medication that is specific for BPD. Again, the medications are often used to treat comorbidities like depression or anxiety, eating disorders, whatever. But for BPD, it's really an inability to properly use the system to regulate emotions. So there are a couple of therapies that are evidence-based. And what that means is that through clinical research, they've been shown to be effective in treating BPD. And typically, regular old talk therapy, going to see a good psychologist once a week, typically doesn't do it. The person might feel supported by that, but they're not really learning how to manage their emotions. They're not learning how to become more effective with respect to their own feelings and their own identity and building a life. So the most researched therapy that's effective was developed by a woman at the University of Washington, Marsha Linehan. And she initially thought that cognitive behavioral therapy, that was the way to go, that would help people with BPD really, they needed to learn how to analyze their thinking. And she thought that would reduce people's suffering from BPD. Oh boy, did she learn that was not true. Mm-hmm. Because people with BPD, when she would say, well, let's talk about, how you're thinking about this, they would get very upset. They would get very angry. Sometimes they would retreat in silence or leave the therapy. These were severely suicidal women that she was working with when she developed this therapy. And what she realized was that to them, cognitive behavioral therapy said to them, there's something wrong with the way you think. This is all your fault. And they just couldn't handle that. So what she did was integrate with these cognitive behavioral skills. She integrated mindfulness and acceptance to synthesize a dialectic back and forth between acceptance and change. And this has been proven in so many studies to be effective to treat BPD, as well as it's now used dialectical behavior therapy in many, many different kinds of treatment. So what DBT does is it balances change strategies of CBT with acceptance strategies of mindfulness, because really, honestly, I can't be any different than I am right now. I just can't. And at the same time, I can look for how I can work to change the next moment. How can I strive to change my reactions in the next moment? How do we synthesize those things? I can't be any different, and I need to do better at the same time. So that's DBT. It tries to really synthesize those things. There are 4 modules in DBT, 4 different skill sets. And a person who goes into DBT therapy typically gets once a week skills group, once a week individual session with a therapist, 24/7 phone coaching, and psychiatric involvement as necessary. And the 4 modules are distress tolerance. How do I tolerate the intense and horrible feelings that I have right now? My old strategy was to cut myself watch me bleed, and that would bring down my emotional arousal. I was focused on this physical injury. So how do I tolerate that distress without hurting myself? Mindfulness. How do I stay in the present moment? How do I understand what's happening right now? How do I feel right now? As opposed to, this is never going to be any different. I can see that person and I'm imagining 100 things that they're thinking about me. How can I be mindful of my experience in the present moment? Interpersonal effectiveness. How do I ask for what I want? How do I improve my relationships with people? And emotion regulation. When I'm spinning out of control, what are the tools that I can use to help myself manage my own emotions? There's also a newer treatment, mentalization, that I don't even really like to talk about this because it's not available in the United States. Really, it's being used a lot in places like Australia and New Zealand, but you really couldn't really find this kind of therapy in the United States. There have been 3 controlled studies that have had promising results, and the treatment was researched in an 18-month-long day program. There are a couple of providers in, I think, Boston, Houston, and LA, but it's not an easy therapy to find. And we certainly hope that it will become that way, but right now it isn't. It did, in these 3 studies, show promising results, about the same as dialectical behavior therapy. And I just want to say that DBT seems to work in about 2/3 of cases of people who have the diagnosis of borderline personality disorder. So it's not perfect, and it does help a significant number of people. Then there's good, just psychiatric management, um, which is good if you can't find a DBT provider. It it encourages looking at the stressors that you feel curiously rather than impulsively. And it's more easily learned than DBT is by a lot of clinicians. So this is a good way of addressing BPD, particularly if you can't find a program that otherwise seems suitable to you. So if you're looking for a treatment, we always say, look for a treatment that is evidence-based. Look for the data that shows that this treatment is effective. DBT is the most researched and currently the most available and most sought. But any specific treatment for BPD is better than just treatment as usual. So if you go to a therapist and they may be a very good therapist, but if they don't know anything about BPD, then it's not likely to be particularly useful in your situation. And again, like I said earlier, family involvement in treatment, if the family involvement is effective, is super, super helpful. If the family and the person and the therapist can work together and be on the same page, that's the best predictor of good treatment. So we know that with effective treatment, there's hope for safety and stability, good relationships, employment, going to school. Essentially, what Marshall Linehan said, the developer of dialectical behavior therapy, she said, the goal is for the person to build a life that is worth living. That's the goal. And I'm here to tell you that that goal is achievable, totally achievable. I mean, there were years when I really did think that my daughter would be successful at a suicide attempt. And, and I thought maybe all she'll ever be is a homeless drug addict. And I'm happy to say that she's just graduated from college and is talking about going to social work school. So, and I really credit both her DBT therapy and my involvement in family connections, which we really worked hand in hand to help her get on a better life path. So the family support has been researched for people with BPD, and it turns out it's pretty critical that, again, higher emotional involvement by family predicts a better outcome. And at the same time, there has to be a balance. Family members have to feel like there are some limits that they need to observe. I know at our worst, my entire life was taken over by um, borderline personality disorder. I couldn't function at my job. She was suicidal. I spent all my time um, policing her. I went around the house. I got rid of every sharp object that I could find. Didn't matter to her. She just took a paperclip and ripped herself with the paperclip. So I was really out of control as well. I had no balance and could not effectively help her. And then I got into family connections. And this is the family experience that people come to family connections with. And believe me, I felt every single one of these things, every one, often all at the same time. It's not a good feeling. So family connections. Family connections it's a course for relatives. It's not for the person with the diagnosis themselves. This is for us, for relatives who are trying to support somebody, who are trying to figure out how to be that effective, involved person. Most of our people in family connections classes are parents. Although we do have also, we have adult children of people with BPD, romantic partners and spouses, siblings. But a big proportion of our population is parents. It's led by trained volunteers. We go through extensive training to lead the class. And the goal of the class is to learn more about BPD symptoms and what is this thing that we're dealing with, and what kind of skills can we use in the interpersonal environment to help make a positive contribution rather than contributing to the stress and dysregulation. And also that really important component of stress and community that we've been hearing about all day. So we have a big community of people who have experienced BPD from many different perspectives, including themselves, their own lived experience. So we are really a combination of the people with lived experience, the family, and the clinicians. We have clinicians on our board. We have clinicians who regularly offer programs for family members. I think there are usually one or two a week. And they continue to guide the program to make sure that we always adhere to the evidence of what is effective. So the groups are held over 12 weeks. Occasionally there's a weekend intensive if our wait list gets too long. We have about a 4 to 6 month wait list to get into a class. And they're both in person and online. And they're available in, I think it's up to about 30 countries now, and in several languages. Wait, before we get to that, I want to say there are two classes that are two different programs that are offered now. One is the basic family connections that I've mostly been describing. The other one is about managing our trauma if we have a child who has repeatedly tried to complete a suicide attempt. So I know I had horrible PTSD um, from many suicide attempts and related behavior that my child engaged in. I was a mess and not functional. And every time she left the house, I would hyperventilate and wonder whether this was going to be the time that she would not return. So that class is it's called Managing Suicidality and Trauma Recovery. And that class really helped me to understand my own trauma and my own PTSD from that behavior of hers, and how to deal with that so that I wasn't reacting always to her out of that trauma and PTSD. So one very basic skill that I learned in that class was check the facts. So if she's leaving the house, and on other occasions when she's left the house, she's ended up drinking herself into a stupor on the New York City streets and gotten sexually assaulted and ended up in a police station, I'm like, oh my God, I'm not going to let her go. She needs to stay home. You can't go. Who are you going with? I would go into overdrive. And what I learned was check the facts. How's she doing right now? Is she okay? I'd ask her, what do you think you're going to do? How are you feeling? And it was, it just helped me be much more in the present moment with her rather than reacting out of my own trauma. So just one little example of this is kind of a basic idea in family connections. It's about the transactional model. So let's say I'm with my kid in a restaurant. She's done something, she got good grades, so I'm going to take you out to your favorite, it was called the Chat and Chew in Greenwich Village, where she could get a really good hamburger with bacon on it. So we go there, she orders her hamburger, she tells the server, no pickles, please. And she's in a good mood. Everything seems great. The server brings her a hamburger. She takes a bite of it, and there's a pickle. And she loses it. She just is like, my fucking sandwich has a pickle on it. And she's yelling. And so, anyone want to guess what I said? It's just a pickle. So I say that to her, which then causes her to pick the table up and slam it down. Glasses of water, plates of food on the floor, and she runs out. I said, well, you could just take the pickle off the sandwich. And she's totally dysregulated. And it took me a couple of hours to find her. And so I learned that is not the transaction that I want. So what do I do to change that transaction? How do I make this transaction more effective for both her and for me? Well, I could understand, first of all, her vulnerabilities. She really doesn't like pickles. We've been down this road before. I know that seeing a pickle, even on the table, is going to be upsetting for her. So I know that she has this vulnerability to pickles. And instead of saying, it's just a pickle, I could say to her, ah, that sucks that the server didn't get your order right. That really sucks. So she feels validated rather than invalidated by my saying it's just a pickle. And um, so maybe she could then communicate a little more accurately rather than exploding. She might say, I'm really pissed about this pickle. And I could say, yeah, it really sucks that you tried to order this hamburger without a pickle. And so we could have a different kind of transaction. So this is just a really superficial example of what we start to do in family connections is to tease apart these kinds of interactions, starting with what's the person's vulnerabilities at the moment? Um, are they hungry, angry, lonely, tired? Are they really stressed about something? Did they have an episode of dysregulation yesterday? And so they're a little aroused today. What are all of those vulnerabilities? And how do we change that transaction so that they communicate more accurately about what they're feeling? And we are able to validate their experience, understand and validate their experience. Doesn't mean we agree with it. It does mean that we recognize and affirm their emotional experience in that moment. So again, this is the program content of Family Connections, information, the psychoeducation, diagnosis, research, treatment, how BPD is developed and what causes it to be maintained for a particular person, mindfulness and relationship mindfulness skills, like what, mindfulness means paying attention in the present moment to another person on purpose. And so when I started to learn mindfulness, the interactions between me and my daughter really changed because I was learning to manage my own emotions. I was learning that when she was hurling curse words at me, rather than to say, don't talk to me that way. We don't talk to each other that way in this family, which, by the way, a therapist advised me to say to her, which just made her feel like, well, I don't belong in this family. And instead, I could manage my own emotions and say to her, tell me what's going on for you right now. I hear all of this from you. Tell me what's happening. So emotion, self-management skills, and relationship and family skills. Family Connections has been the subject of a fair amount of research. I think there have been 8 full-blown research studies in the United States where people who start the class are interviewed and their level of grief, burden, stress, and their skills are assessed at the beginning and then at the end of the class. And these research studies have all shown that Family Connections helps people, it lessens their grief about the situation. They learn how to grieve and how to accept what is happening. It decreases their sense of burden, decreases their sense of isolation and stress, and teaches them skills. So the class itself has a very high satisfaction rating from people who take it. We do pre and post course surveys. And then this is the MSTR, Beyond Trauma and Suicidality class that Family Connections started 25 years ago. And this class is about 4 years old because we Family Connections leaders noticed how many people came into our classes And we're dealing with a child who was suicidal. And so some clinicians, again, from McLean Hospital at Harvard and Brown Hospital in Rhode Island, helped to develop this MSTR class, which is focused much more on trauma and on our trauma and how do we recover from that, in addition to the other family connection skills. So these are just two recent testimonials. I'll let you read them. I certainly know as a family member, not a clinician, I, had no interest in being involved in the mental health world, believe me. And as a family member, again, this class really saved my life. I thought that I was going to live the rest of my life in total despair. I had gone to China to adopt children thinking, oh, I'm going to make this family. And it felt like a disaster to me. And I had no idea what to do. And we had been in many, many different kinds of therapy, adoption focused therapy, you name it, we had tried it, and I was broke. And then I stumbled on Family Connections, and it really taught me skills, both to understand what was happening for my kid and how I could be that kind of effective, emotional, involved parent for her. And, we embrace the mindfulness that Marsha Linehan brought into dialectical behavior therapy, a lot of which comes from, has some roots in Buddhism, including Thich Nhat Hanh, who has been kind of influential for us. So that's it. I think we have a little time. Questions? Yeah.
So how is BPD, who diagnoses people? How would you get a diagnosis of that? And do people taking Family Connections, does their family member need to be diagnosed with it, or could they just come and find out about it if they suspect?
The family member can, if they're dealing with a person who they think has trouble managing and regulating their emotions. Remember, BPD it's a disorder of emotion regulation. So if your person seems to be having a lot of trouble regulating their emotions, then Family Connections is a place for you. We don't require a diagnosis. We don't ask about diagnosis. We figure people have enough to worry about without having to get a diagnosis. The MSTR course, the one about suicidality and trauma recovery, is transdiagnostic. Like, you don't have to think that your child may have BPD. If your child has engaged in suicidal behavior, then MSTR is a class that can really help you understand how to manage, yourself, and again, be effectively involved. Yeah.
Is there any study or knowledge, or do you have any knowledge of whether parents with BPD who are raising their children also are more likely to have BPD?
Well, again, the inherited part, there's no gene for BPD. There's no, blood test that you can do for BPD, but parents who can't regulate their emotions, kids, is it inherited? There's no evidence that that's the case, but a parent who has a lot of trouble managing their emotions is going to have a lot of trouble effectively parenting a kid. So we do see in classes lots of adult parents, and by adult I mean 18 or older, adult kids who feel like they're just, all their emotions are just in a swirl. They also have some dysregulation.
And for those who come to classes who also themselves have challenges with emotional dysregulation, do the classes help them manage
Yes.
their own?
Very much, yeah. Because again, the classes teach, like we start with mindfulness. How do I know what I'm feeling? What am I, like, all I know is that I'm upset. You know, what does that mean? And how do I identify that? How do I identify my emotion? And then what are skills that I can learn to manage that emotion and relate to others more effectively? So yes, they find it very, very helpful. Yeah.
Once a family has been through the 12-week program and they've learned these new skills, there any kind of ongoing support groups for them to like keep practicing that and keep getting the support that you were talking about?
There's a lot. There are weekly skills groups and skills refreshers, usually led by clinicians. Those are usually done in like an 8-week series. So if you're having trouble figuring out, you know, how to set a limit for yourself, and you feel like your self-respect has been trashed because you're walking on eggshells all the time and you just can't figure out what to do, and all you want to do is hide under the bed. You know, there might be there will be a session on you know, how to observe your limits, how to start valuing your self-respect in the whole equation, so that you can get some balance. So there's that. We call this the Alumni Institute, and we're also people have said very much that they want small ongoing support groups, and we're trying to figure out how to do that. This is it's almost entirely a volunteer organization. So, you know, you all know the problems of that, right? Yeah. Other questions? Yeah.
So it sounds to me like a lot of the like symptoms of BPD are like a response to me seem like sort of normal responses to trauma, right? And I think like a lot of times people who experience trauma or survivors of trauma, they often are then responsible to do all the work. And so I know a big component of this was like inclusion of family involvement. Within the program, is there also conversation about like family ownership and accountability for their potential role in the trauma?
There's a lot of there is a lot of emphasis on how did I participate in this situation and how can I participate in a better way. We don't talk about like, what did you do to cause this trauma that this child went through? So we really are pretty committed to a no blame, no shame, no judgment kind of environment. It's just whatever you did at the time was the best you knew how to do then, and you can learn to do a lot better. So it's that, again, that dialectic between acceptance of what has happened and change. And that's where our focus is that we have a responsibility to learn how to do better and to change.